Good afternoon, everyone. We're going to make a full meeting of Tuesday, September 12th. From Squamish, Peace Classical Squamish, Oweomeo, which means welcome to the traditional territory of the Squamish Nation. There's an agenda for the committee. I'm looking for a motion to adopt by Peter, second by Ted. All those in favor? Opposed, if any, motion carries. So first up, really pleased to welcome Karin Olson, who's the Chief Operating Officer for Vancouver Coastal. I guess you've been in that role for
1 year today.
almost, wow.
I flew in on September 12th last year, so
Nice.
you've got me on great timing.
Fantastic. Well, happy birthday. And I know when we talked, I guess, last spring,
March, yeah.
March, April, you talked a little bit about how one of your focuses was to bring some energy to the Sea to Sky region that had sort of been a little bit overlooked in the recent years because of all the stuff going on in Sunshine Coast and other areas. So one of the things that council never really had an update on was the master plan over at the hospital and some of the other services in the community. So I know we've had some scheduling issues, but really pleased that you're here in front of us today and we can have a conversation about where your plans are and what's going on. So welcome.
Well, thank you very much for having me. I'm wondering, could I just read you a bit of a roundtable discussion?
Absolutely, sure. I'm Patty Ungar.
Susan Chappelle, Councillor.
Ted Pryor, Councillor.
And Doug Grace, Councillor.
Linda Glendale, CAO, we met.
Karen Elliott, Councillor.
Peter Kent, Councillor.
Hi, I'm Jeff Simmons, Senior Director of Human Resources and Public Safety.
Great.
Sarah?
Hi, we met. Yes, she
And
has a download for me.
happy if there's anyone here that's here for this conversation in particular. We try to make these committees very open and collaborative, so if you want to join us, just put your hand up, come up.
Yeah, and I thought I would introduce a delegation only meant one. I had to be more than one to be a delegation.
Cool.
So we have 5 directors that are now serving the Sea to Sky corridor, so it's a very different model than what we've had before, each with some expertise. And 2 of them agreed on very short notice to come up with me. So I'd like to introduce Shannon Tuskoff, who has Squamish with their Pemberton Acute Services, except for the surgery side. And Corey Irwin, who's the director of the surgery program, both for Lionsgate and Squamish, but we're trying to build a coastal network of surgical services. Corey covers that area as well.
Please join us at the table. Yeah.
Sit, have a seat. Yeah, sure.
Any seat.
Thank you. So what I thought I'd do is, I'm not going to do death by PowerPoint, I promise you, but I thought I'd give you a little bit of an update of where we're at, and we've made quite a few changes in the last year, including changing the model in terms of coverage for Sea to Sky corridor, in particular Squamish. What we had before was 1 director, 2, I guess if we looked at it, that covered Sea to Sky corridor, including Squamish, West September, all of it. And we've looked at the specialties now within the director portfolio for coastal, being mental health, who is Shannon McCarthy, Sujata Connors, who is home and community care. All of these are directors. Keith McBain, who's Hilltop residential care, but he also has residential care across coastal, and also be working on the hospice build at Squamish. And then Shannon and Corey as well. So rather than 1.5 directors, you now have 5, of which in any given week, 1 of them are up here working on some aspect of the care. So a bit of a different model, and I'm certainly eager to have the others come up and meet with you. Now I am left-handed, but I'm also somewhat blind, so I don't know which one is my
I can help you with that.
great, because once I'm up, I'm good.
Yeah.
Thank you. Technically challenged. Never would say I'm not. Yeah.
Okay, it's just a second. There you go. So that's your next one, just look at.
Oh, okay. And I just mouse my way down, or do I just hit down?
Use the arrow.
Okay. Okay, I think I'm there. Yeah, I'm good. Yeah.
And I know there's someone in the audience who's interested in the next agenda item, so we will be on this topic until 2 o'clock.
I probably will be shorter than that, just to give some people some hope here. So just a very quick overview of Squamish General Hospital, which you're probably very aware. We do provide quite a multitude of services. both surgery, obstetrics, which is a growing business up here. I think everybody's having a baby, even if you're not of childbearing age. Palliative care, physiotherapy, pharmacy, supporting services, diagnostic imaging laboratory. We do have ambulatory care as well as chemo, a chemo clinic here, satellite, and then our emergency services. Within the emergency room, we have 7 stretchers, but that also serves to provide other services other than emergency care. And the labor and delivery rooms, where we say that we have approximately 250 deliveries per year, I would say we have significantly grown. I would say it's more than 50%. I think we're hitting closer to 60 or 70%. You put one obstetrician in town, and I'm not sure what happened, but I do know, obviously, with a large growing young community here, people are choosing to come live and be here and grow their families here, which is great. But it's created some other challenges for us that we're working on. We have only operated 1 operating room suite, even though we had 2, and I'll speak to the expansion to the second one now as a real opportunity for Squamish, and I think you've seen some of that in the news. And then the more than 14,000 patients per year and growing. The Hilltop House, which is one of the newer Hilltop build, is one of the newer builds within Vancouver Coastal, and houses 110 long-term residential care beds. In terms of the volumes, when you look at Squamish, one of the things that we haven't seen, and I've got a slide at the very end that I'll show you the complete difference, is we have not seen a large growth in emergency visit volume. So that means 2 things. One, that you have a reasonably robust primary care network, and that community supports are in place, where we haven't seen a large growth in the visits. So the top green line, we should look at different colors there, is the 2017, just up to the last period. We work on fiscal periods from April 1st to March 31st. It's very seasonal, as you can see, but again, not a huge growth in our emergency visits on a regular basis. What we have been doing is quite a few different things for Squamish, also with Pemberton. One of the big things that's coming is called CST, which is Clinical Systems Transformation, which boils down to really putting in a new information platform that allows clinicians to be able to document electronically in a manner that allows the clinicians at other sites, if appropriate, if a patient's being transferred or a primary care physician wants to view what's happened to a patient in the hospital, that information can be transferred digitally rather than relying on a chart being photocopied and transferred. So what I always say is, if you've been a patient at St. Paul's Hospital, for example, and you had open heart surgery, you come back and you show up in the Squamish Emergency Department on a Friday night at 2 in the morning, and let's say English isn't your first language, and you're obviously in distress. At this point in time, what would happen would be the physician would run a bunch of tests. They would try to get a hold of the cardiac surgeon, who may or may not be available at St. Paul's, and they wouldn't have access to the record of what actually happened in St. Paul's. And they would prescribe the usual drugs for cardiac failure and so on, not recognizing that that particular individual had a reaction to the most common one, and therefore increasing issues. With the new record, and it's going across 3 health organizations, including PHSA, which has Children's, and the Cancer Agency, the record will be visible across VCH, which is all of the hospitals and sites, acute care sites, Providence Healthcare, and PHSA, so Children's, Women's, and Cancer Agency. So what will happen differently when that same patient arrives in the emergency department is the physician can pull up the whole visit from that patient who was having cardiac surgery at St. Paul's. We'll find out what surgery the patient had. We'll also know that the patient reacted to a specific medication, and may reduce the number of tests they'll do, because they'll realize not only did the patient not on that medication, they didn't fill the prescription. So all of that information now becomes visible to clinicians who are trying to provide better care. That is happening, and it's not a small project. We started this 4 years ago as 3 organizations, and we are now at the point where Pemberton and Whistler will be going in the February-March part of, in terms of going live then, and Squamish and Lionsgate will go live together around March. So the training for all the staff will start in January. This is a large initiative requiring Wi-Fi installation, lots of portable computers on wheels and workstations on wheels for staff to be able to do their job. It is a completely different way for staff to be documenting and caring for patients. We'll also have an element of something called closed-loop medication, which when you go to Safeway or Stong's, when you slide something past a barcode, you know that people know what you bought and how much you paid for it. It's the same idea. Wristbands will be barcoded, the medications will be barcoded, and there will be background intelligence in the computer to say, when you scan the wristband and you scan the medication, am I giving the right medication to the right patient at the right time and the right dose? So it increases our medication safety significantly by having this. And as much as we all enjoy doing, what is this doctor written, because they do write in Sanskrit, we will now be able to actually read what they're inputting into the order sets, because those will be what they call CPOE or clinical provider order entry, and that will go straight digitally into the order sets. So much safer, improved communication, and in terms of medication safety, much better. But to standardize this across 3 organizations, at least 13 emergencies and well over 20,000 employees, plus all of the physicians, it's taken a long time. But we have installed the devices in all of the sites. I think we're just finishing up now with Squamish. So we've done Pemberton, Whistler, Squamish, and then we're moving on to Lionsgate. I think we're just about finished, aren't we? My 2 favorite ones, the oxygen supply system, the tank farm, and the emergency generator, which has been generous contribution from the RHD on. The reason the oxygen system supply tank farm is saying planning is we've actually had some input from our facilities people who's saying, given the opportunity for disaster planning, would it make more sense to do your own oxygen here and do it with a concentrator? So the funding has come through. We're going to move forward. We're just wanting to find out what's the cost difference, if there is one, versus having a concentrator and doing our own oxygen here in Squamish versus expanding our tank farm so we don't rely as much on transportation on the Sea to Sky Highway. The emergency generator, power generator, which is, and the power distribution plant are in design development and will be installed in this fiscal year. And then very much needed is the hilltop boiler, which last year, and of course one of the colder years, we had the boiler go down more than once, and it was quite compromising to our seniors, or potentially we were looking at renting a whole bunch of heaters just in case as our backup. So those are the site upgrades right now for 2017 and 18. Each year, the directors get together and they look at what other, along with our facilities people, to look at what else may be needed in terms of keeping the lights and power and everything else going at Squamish, or upgrades that are needed. What I haven't put in there is the new hospice development, and I think it's in here, but if not, that is well in hand now in terms of just about ready to go for RFP, I believe, with they're doing the architectural design going forward. But that is well in hand now too. The one thing I am insisting on, just so that you, in case you hear of the horrors of Philp, I am insisting on a demolition, or at least going into the walls to find out what's behind them before we issue an award, so that we're not surprised by asbestos, poor craftsmanship, or something that's going to increase the cost. So the Philp certainly went through that. Any questions about that previous slide?
One of the challenges that we have at the Regional Hospital District Board is reconciling what types of projects we want to fund through the RHD, and what really should be ongoing maintenance, planning, upgrades by the Ministry of Health and Coastal. And if you go back, if you just go back to the list, and we did.
You and I talked about this.
Yeah, we did partially fund, not to the extent that I think the Coastal wanted, but we did partially fund the oxygen emergency and the power distribution. I believe we did all 3, but not to the 40% that we theoretically could. But we did decide to fund hospice significantly, and I'll leave to Director Race over there. to the tune of $600,000, if I remember correctly.
Just under 7.
Yeah. And because we really saw that as, you know, something that's really augmenting service in the community, that's community specific as opposed to general maintenance things. Past things that we funded to the RHD have been the chemo hood here, pharmacy in Squamish, the heliport. Just kept going on and on and on and sinking money into the RHD for years in Whistler, as well as the, not the MRI, the other one, the CAT scan in Whistler, and some Pemberton specific around the clinic there. But those things really augmented or added to service. So that's where we have that tug is we get these requests for these sort of mundane things that we think, well, oxygen, you should be planning for that over the long term, or boiler replacement, that should be an ongoing maintenance issue. So maybe just from your perspective, I know there's money's always short in health. It's 42% of the provincial budget. It's a lot of money, but that's where we sort of at the RHD.
Right, no, and that's fair. That's a tension that I think many of the RHDs have. And certainly the equipment and the new is more fun to do. Quite frankly, it is. Our capital, our MCI and RCI are constantly shrinking, so we get fewer dollars to do renos and the main part. And it's spread over, as I said, for coastal, it's spread over quite a few communities, 7 different communities that we're trying to support going forward. So many of these things, and when I look at the oxygen and emergency power, those ones make me very, very nervous because we know that disasters can happen and you could be cut off on the highway and you need to be able to be more self-sufficient. So, but also the roof in Bella Bella Hospital also needed to be replaced. So the list of high-level, just keep the lights on issues and the amount of money that we get in our community of care versus, and also the rest of Vancouver Coastal is diminishing. So we do come to the RHDs to ask for some support with it. Also like to balance it though, to be fair, with things that add value from all of the public's views. I mean, if the oxygen tank farm and the energy, the emergency power generator go down, we're in trouble altogether. But being able to invest also in the hospice, I think it is a balance going forward, and if we were coming forward each time with only things that are, feel like just general maintenance, then I can see where we're going to have a problem. But I think there'll always be a discussion on it, and we can't not ask. That is one of the things we do with the RHDs in terms of the funding. But it's a discussion each time, for sure. And I do appreciate the work, and that's, again, why I'm working on the oxygen, to say, if we can do this ourselves here in Squamish versus just expanding a tank farm, I want to make sure that we're spending every dollar the best way we can in terms of sustainability. Interestingly enough, Lionsgate does not have a concentrator either. So you would think we have a tank, a large tank, that it just doesn't make sense. So it will be discussion every time. I can't give you a better answer than that, but I think the money's shrinking. And
no, I know. The other piece to that was the conversation we had with the hospital foundation, and figuring out a way to fund all these projects that need to be funded, where we're actually leveraging as best we can the modus operandi of each organization. So for a foundation, they can fundraise way more easily for a CT scanner or a chemo hood than they can for
absolutely
fixing this elevator or replacing a roof. So really being able to leverage the different entities to collectively achieve the goals that we're trying to do. I don't think we've really done that really well in the past.
no, I think there's an opportunity to look at this very differently as well. So one thing I don't think has gone well in many of the rural communities, and we maybe are a bit more robust at Lionsgate, but I've certainly talked to Hull River and Seychelles as well, is sitting down and sharing our capital list, our requirements of our capital, some of which is equipment, some of which is the wear and tear, elevators and things like that, of which we try to make sure that we distribute the major capital money out across coastal. But it is also never going to cover the whole list. It just isn't. So we could sit down with you so that and also with the foundation, because they do want to, they're more onto the equipment and things that people see an immediate return on.
The shinier.
Yeah, yeah.
They can
Shinier,
fundraise
sexier
for more
objects,
investment.
yes, sure, and that's fair enough. So we've got the same thing that we've done at Lionsgate, we're gonna do with all of the communities in terms of sharing our capital list and why and how much it's rated at too. It may be on the list as a level 3, which is not critical, versus a 1, which is critical, and with the brief explanation beside it as to why we want it as well.
And just my last sort of
Yeah.
hospital district thing, there used to be, and it's part of the MOU that we
Coming,
signed,
we're meeting.
a yearly meeting. There hasn't been one for about 4 years now.
Yeah.
I talked with Clive at last year's UDCM, he said, oh, that's an oversight, we'll get one done, that's a year now, so.
Clive is actually setting it up. Trust me, I
Oh.
would never have shown up here without making sure that I had that one well
Because we
in
used to
hand.
discuss all those capital projects,
Absolutely.
that everyone, we
Yeah.
understood the whole context of the capital demands on the whole region.
Yeah, and it may be helpful for me to bring the existing capital, both from the major capital and also what we're investing in RCI, which is more of the renovation type piece to that meeting. But no, Clive's definitely
Okay,
setting it up. We're also doing local governance liaison meetings this fall as well. I
Okay.
didn't get a chance to do them last year because of the election, well, I was new. But also then the election piece started happening and it felt like a bit of too much competition apparently. Clive said this was not the year to do them, so I'm back on for those as well.
Okay, awesome.
Okay.
Michelle?
Thanks so much. Do you want to finish your
Yeah, I
slides?
think
before
Maybe I will,
Yeah,
and see if I
let's-
cover it, and if I don't,
absolutely.
you know, feel free, because
I
I'm,
was just looking at my list thinking you have more slides.
I do have a few more, but it won't be tons more. The other piece that we have is the experienced resource nurse staffing for Sea to Sky corridor. So what that is, and very much thanks to Shannon with the work that she's done with our corporate employee engagement or HR department, is taking the model that we've had in other hospitals, larger hospitals, and actually expanding it up the Sea to Sky corridor. So what we do know that happens is we'll be short staff. We'll be short in Pemberton, we could be short in Whistler, or we could be short in Squamish. And the ability to move staff between is rather limited. And they also have to have a certain experience level to be able to do that. So to be able to fill some of the vacation or the vacancies, vacation or short call, these people are scheduled already. But they also, and they can move between these different sites and also work at Lionsgate as well. So they're a very specific group of people that are on round the clock, are they? Yes. Yeah. Just starting actually. And it will help bolster some of the gaps that we will have and have had in Sea to Sky, probably more importantly in Pemberton. You know, I'm sure you've all heard about the Pemberton Clinic and not having some of the shifts covered there. So when you go down one nurse, that's a huge gap in just about any one of the sites here up the Sea to Sky corridor. So having this as a backup is going to be really important for us, and it's not been done before, so it's really stretched the minds of our HR department in terms of working with us, and I think it's going to be quite successful. You have a new manager that's working in these areas, Suzanne Scott, who has an Emerge background and has been able to recruit not only into Pemberton but also into the sites in Sea to Sky and work with these ERNs. And I think it's a good model for us to be using. Second one's a bit of a titchy one, but I didn't want to leave it out. The forensic testing for sexual assault victims. As you know, we have a Monday to Friday, we have forensic testing available for sexual assault victims. What we don't have is an ability out of hours, so past 4:30 in the afternoon, really to be providing that service, which is a problem. On the other side, you need exceptionally well prepared people to do this service because it can impact a case further down the road. So this isn't something where you can just throw someone in because they are most often going to be required to testify for the victim in the case. So you want to make sure that you have very skilled people doing this testing. In some sites, the physicians are the ones that are doing it, and others, it is the nursing staff. Sujata Connors was the new director, was actually reached out to her Northern Health colleagues because they're experiencing the same issue. We're not alone in this. And we're working with Northern Health and Interior Health Rural to find out, okay, what are you doing and how can we provide this service in a way that's comprehensive, but also in terms of the testing, but also in a way that's going to be not safe so much, but certainly in terms of safety, we want to make the people feel safe, but not contaminate the ability for them to have a successful outcome if they do go to trial. So it's a bit of a balance. So we're working on it. We don't have a solution yet, but we are working at a more of a rural provincial level to come up with a solution, because this isn't a problem that's unique to Sea to Sky corridor. If anything, we actually probably have an easier route, believe it or not, to Vancouver, the Center of Excellence for this. But that said, a person who requires this service is already feeling exceptionally vulnerable, and having to go and drive or wait is a pretty horrible thing to do. So we need to find a way of being able to do this in a safe, experienced, and timely way, and we don't have that answer yet.
And just a question about funding on that, it's 100% funded to the health budget, there's no funding from justice?
Not that it is not, it's all through.
I know, I knew the answer to
Yeah,
that question.
yeah.
My point is that this is for prosecution. This
Mhm.
is for ideally having secure convictions.
Yes.
And so a conversation between the health and justice needs to happen, because justice should be putting the funding towards assuring that we have solid cases. It's not technically a health issue, the forensic piece, although health professionals need to
They
do
do.
the testing, but the funding should be
Yeah.
coming from a different department.
The testing piece, and I don't mean to minimize it, is a small piece of this. It is the counseling and follow-up for these individuals that really does fall under the bucket of health.
Agreed,
Yeah,
not the forensic testing,
Yeah.
agreed.
yeah. So I put it up there as forensic testing, because that is the
Yeah.
immediate issue and what's hitting your papers. But really, it's like saying we're going to admit people with eating disorders to Squamish Hospital. You never do that, because it is a whole program. It's not just putting them into a bed. So, we've been down that path at a different hospital on that too. It is truly a more fulsome program.
Yeah, why don't we just stop here, because I know this is
Yeah.
a topic of great interest for council. So
Sure.
are any comments or questions about forensic testing? Susan?
Thank you, and yeah, I appreciate all the work that's been done in Squamish. It is more than we've had. But also, I'm wondering what about the opportunities. Other hospitals have moved to more comprehensive care, where you do have, we're currently, if you are a victim of a crime, you go to the hospital between 9 and 4:30, Monday to Friday.
Yeah.
And the comprehensive care does not happen. We don't have a system that involves mental health and actually
That's
a
right.
team program for this service. So I think provincially this needs to change. I don't think it's a local issue or really a health authority issue. And I do agree with, my lobbying is to get the Justice Department to actually put the funds in so that it doesn't become an issue of healthcare budget continuously.
Yeah.
But
Competing with other
competing with other, exactly, where you're cutting one service in order to fund another service that may not be utilized as much. But that full 24-hour care, comprehensiveness, and ability to refer within our community and have those services available. The other piece of that is the Northern Health piece, is that currently our funding is being pulled into North Vancouver, our community funding for Northern Health. We don't have a lot of services being made available locally. A lot of the funding is going into North Vancouver. Do we have any planning that's interactive with First Nations and the Northern Health Authority to make culturally appropriate services across the board, not just forensic testing, available for First Nations?
I'm not sure I understand when you're saying Northern Health and then North Vancouver, what funding is being pulled from?
They're building I believe they're building a healthcare center in North Vancouver that's actually taking a lot of the resources from, like our workers and everything else are now going down in North Vancouver.
I don't, for healthcare?
Yeah.
No, there's no building that I'm aware of that's being built in terms of a healthcare facility.
I understood there was a Northern Health initiative, not
A
a
Northern
Vancouver Coastal Health initiative.
In Lower Mainland?
In Lower Mainland.
Northern Health is like.
It's.
No, sorry, the First Nations Health Authority.
Oh,
Sorry,
it's First
my language
Nation that
problem.
came in.
Excuse me, sorry, the First Nations Health Authority.
Okay, First Nations Health Authority
Yeah.
covers all of BC.
Yes, but
So, and
the
the,
healthcare resources for the Squamish Nation in our community, a lot of the resources get split between, because the Squamish
Yes,
Nation is in
yeah.
those two communities,
Yeah.
a lot of the healthcare resources. I know originally
Or
we had.
North Shore, not here.
Yes,
yeah,
exactly.
yeah. I haven't heard that, so can we take that away just to
That would
find
be
out a
great.
bit more, to find out a bit more about it?
Thank you.
But I completely agree with you around that we need a comprehensive service and wraparound service. Embarrassingly, I don't think we even have that at Lionsgate, because we send them to Vancouver, which is the center for this. But and by the way, any money that Justice wants to send our way, we're fine with it. We're not turning it away, so just so you know. But it is something that Sujata, as I said, she has many contacts. She came from Northern Health in the community, and so she's been working quite closely with her previous contacts there, and then we're linking in interior health, because it is something that we need to look at as a model, and even if we pilot it and it becomes a model. That's a lot of what we're doing. There's also rural networks now that actually work together on many different things as well.
Health transportation as well, that transportation aspect, if people do have to go, because if people are coming to the hospital after 4:30, what happens if they have to go down? Is it still in the back of a police car? Is there any transportation services with mental health care involved that offer support if you're bringing people outside of the community for testing?
No, at this point in time, I don't believe there is. We have not engaged in any, other than BC Ambulance, we're not in the transportation industry in terms of bringing people down. No, no, we don't. I mean, I can tell you that basically we have a lot of work to do in this area, and we haven't got there. So there's many pieces to it, and also making sure people want to be transported versus who they want to go with and all of that.
It is a barrier for...
Yeah, for many. And the further you go towards Pemberton and past into the Indigenous lands, so when people, one thing that does me in a bit was when people say, well, it's not really a big problem here. I said, no, it's not reported. That's right.
Thank you.
So I know the ultimate goal is 24/7 coverage, but if, I don't know what the statistics are about when sexual assault victims are coming to the hospital. But is there a way to, maybe it's not Monday to Friday, could we do Wednesday to Sunday? Is there, to match the coverage for when you're seeing most of the incidents happen? Or, I know maybe that's an HR.
Well, it isn't actually. It's more of, when are we getting the reporting, and that's grossly underreported, the reported incidents. And it depends on which community you're talking about. So Whistler may have a slightly different need versus what Squamish may need versus what Pemberton may need. As I said, I think we need to figure it out, first of all, in terms of hours of presentation for sure, because surprisingly, people don't report right afterwards. Sometimes they're reporting later. And then figure out how we're going to do the staffing around it, what that model looks like. Is it an NP that's actually more trained to do this and is on call, or who works but then is on call for this as well? We're not sure, and that's why I really want to have the time to, or give the time for us to do it right.
Okay, so just to give everyone a heads up, Karin has to be out of here by 2.
I do because I'm flying to Power.
Yes.
Medical Quarterly in Power River today. Good news story, Squamish OR enhancements. There was some money released from the ministry to look at enhancing surgical services, and one of the areas that we looked at was Squamish for a couple of reasons. One, we have physicians who are traveling quite often to Squamish in terms of providing general surgery, ENT, orthopedic surgery, so we already had that relationship with Squamish. Secondly, they had an OR that was sitting idle. So when we're looking at this additional money, though, this is not to just put into a community for that community. It's really looking at coastal as a whole and reducing wait lists, because the provincial mandate is to reduce wait lists overall. So it certainly benefits the community, but it also allows for people who perhaps aren't from that community, who've been waiting for their surgery, and it's appropriate to have their surgery in Squamish, freeing up OR time at Lionsgate for perhaps more complex patients. I think the neat thing about this is from the day that we decided to do it, and it was 8 weeks later, we had a second OR open. So that almost never happens. You need to know healthcare is one of the slowest moving beasts around. So for the ability to actually take from the idea of why don't we do Squamish, have physicians in both communities, anesthesia, surgeons, and actually be able to coordinate it all at 8 weeks, that was quite amazing. So I've got some stats here, I believe, coming up just to show you what that looks like for the ORs. It's quite amazing, but we have increased the surgeries here, so access to surgery for both Sea to Sky corridor patients and also improving access for Sea to Sky corridor patients who may need surgery at Lionsgate, because we've been able to reduce the wait list there. For orthopedics, general surgery, neurology, plastics, ENT, and gynae, yes. It's been quite significant, and it's seen as, the Seashell was saying, why not us? So there's envy out there, and we'll be looking at those other communities as well. So it also helped shore up the call issue for the nursing staff with 1 OR. People are on call a lot. Having 2 ORs, it's reduced the call burden for the staff, so it's been a great retention initiative as well. I can talk more about that. The Carlisle Youth Centre is located at Lionsgate, or on the Lionsgate campus in the Hope Centre, which is our mental health unit, brand new, opened just a couple years ago, and this unit itself opened up in April. It's one of 2 in Canada, and it serves youth from 13 to 19. And if you look at the pyramid of healthcare delivery services, this being your basic, and the top being your high complex needs, high cost. These kids that come through here have a mental health and substance use concurrent disorder, and this is a place where it's almost like the area of last resort for them, where they're very complex. They quite often are living on the street or have not been able to find a solution in terms of dealing with their disorders. So these are the really complex. So 13 to 19-year-olds, we want to wrap our arms around and try to come up with a plan that will help them go into their adulthood much more productively and also safely. This is open to all of Coastal. It's open to all Vancouver Coastal, actually. And we actually have people sitting on a review panel from all of the communities of care, so that there's a sense of fairness and transparency about who comes. With your very young population up here, it's important, and your physicians are very aware of this unit. It's a 10-bed unit. We've had patients be admitted and discharged since the beginning of April, and some of them quite successfully. But the success rate on it will vary, because these are very embedded behaviors and challenged youth. But the other one's back in Ontario, so very lucky. The Carlisle family donated for this, and it's a beautiful unit if you ever get a chance to come see. We have 5 new operations directors. I'll tell you what I'm a little worried about is this isn't the right slide deck. We'll keep going. Because I had changed this. The TIDES program is the use of telehealth, and which is going to be increasingly important as we try to spread care outside of the bricks and mortar of a hospital to get people home into their community to recover. And it really comes with a hub and spoke idea, where you may have an OT, speech language, physiotherapy person at the hub, and with each of the spokes into the communities, you will have a rehab assistant who will be at the other end with the patient, and receiving instruction and actually performing whatever exercises or things that are needed to be done. What's important about this is, in many communities, I'll use speech language as an example, it's hard to get a speech language therapist, and for us to pay for a 0.2. Nobody wants to work 1 day a week as a speech language therapist. So often people who have strokes, for example, can't go back to their communities because they're phasic, and they require speech language therapy, and they spend their time at Lionsgate, or they rent on the North Shore because they have to come in each day for speech language therapy. These people can now go home and receive their speech language therapy with their families, and be with their families, and or their physio or their OT if they meet certain criteria. So this is getting people home to their communities a lot faster. So we've just started that. Yeah. Intensive case management is a mental health initiative that we've rolled out here in the Sea to Sky corridor, and also in other communities, which is really looking at meeting clients who are discharged and or living in the community, and wrapping our arms around them to be able to manage their care a little bit better from in terms of a mental health standpoint. And the last one is NST, which is your non-stress test testing for your many pregnant women that you seem to have in your community. Rather than having to have them sit in the emergency department, we are trying to move them into a better area to have their non-stress testing, And some even were going down to Lionsgate, which is a heck of a drive to go down and have this testing done on a fairly regular basis if required. And we've just started this pilot, so we don't have any data on it yet, but we're hoping that it's reducing the burden on the emergency department beds, but also improving the experience for pregnant women. Okay. Yeah, this is not, let's see, extra slides. Okay, this got moved. Here we are. So this is the old one. So going back to the master site planning, I just wanted to share with you, there were some interesting things that I found when we looked at master site planning. Because when I actually went and looked at it, we had many different documents that had gone through. In 2013, there was a site sustainment plan and priority opportunities. In May 2014, there was a youth services functional program, which looked at high-level conceptual design. And then in January 15th, 2015, there was a site implementation plan that looked at 0 to 5 years. Thank you for sending me on this hunt, looking for all these things. So while I was going to just kind of pick out what we've done, I thought, no, I'm just going to share with you the latest, which is the January 2015 slides, which I know it's small, but it's the short, medium, and long-term opportunities with, I will say, very high-level project cost estimates. These will not have been validated and provided by our facilities, Lower Mainland facilities people. So this really looked at if we were going to be arranging things differently within our hospital here, what would some of the opportunities be? So our medical daycare center, obviously looking at an addition for that. And when it says NA, we haven't started on any of these, because I do think we have to go back and revisit all of this to say, okay, what makes sense now in 2017 based on these. The surgical and MDC addition, just to increase our capacity, given what we're doing with our surgery component and our growing medical day center, we may need to do something quicker. The laboratory upgrade, the lab has come forward with requirements, as has our pharmacy actually, to say that these are things we're going to have to be looking at in the future. Our health records relocation, we can take things off site, and there's no reason why health records, especially as we go to an electronic record, why we couldn't have things off site. So again, there's some dependencies. If we expand our diagnostic imaging, we would have to move health records. So some of these are dependencies. The electrical and mechanical services, we certainly, when we looked at that, we knew that we had a problem. The emergency generator and the power distribution will help. So those, you have air conditioning, all right? Yeah.
That's another topic.
Yeah. Okay. So that's the subtotal of the short term. And there's intermediate, which was looking at the diagnostic imaging upgrade. There was the ultrasound room is one part of it, but I also don't want to leave out the whole thing around the CT scanner, because I know that Dr. Cudmore, who's retired from his position as the local medical director, but not from the community, his passion was the CT scanner. We did do an impact analysis, also just a population analysis, whether we're ready for one. It's not that we won't have one, but it's that we're not quite at the demand level of where we do need one.
Right to MRI now.
Okay, great. Super. Just give me something else to stay with. No, well, and there's some varying opinions on the a CT scanner versus an MRI, but I'll save that for a different meeting. Expanding our acute care nursing station, for anybody who's been there, you know that it's not most ergonomically friendly station. We would not do any of this before we do the CST implementation, find out what happens with workflows, because while we're putting an information system in, what this is going to do is change workflows. So we need to get that in person, understand how much have we really messed with people's lives and their ability to do their work. The rehab gym relocation, again, that was really dependency based on what we would be doing with other things. And then our community dialysis unit. We've had some significant interest from a new director on having that relocated or at least expanded. So we're having discussions with that. quite frankly, we don't have one in Lionsgate. It's down at the bottom of Lonsdale on Esplanade, and that's where they do the community dialysis. It's not located at the hospital, and it doesn't have to be. People who are having their dialysis actually in a community dialysis unit are very stable individuals, so that may be real estate that we can claim back. And in Ontario, they do them in malls. You know, so after you shop and you feel a little better, you go and have your dialysis.
Top up.
Yeah, top up, exactly. And then the longer term is the acute surgical services addition and renovation. Well, without actually adding anything at this point in time, we've already maximized on the second OR. And what I didn't tell you was well, I'll show you the slide in a minute because I think it is coming, the number of ORs that are coming here to show you the volumes we've actually been able to increase just by doing the 2 ORs, which made so much sense. To have one sitting dormant just did not make sense. So without having to spend a lot more money in terms of renovations, although it is going to push us to do that because of our sterilizing area and everything else we're going to have to look at. The ED decontamination room addition is something that we do need to consider. It's not sexy, it's not interesting, but it's certainly something that I would see that we should be looking at for this community as it is growing, and there's good reasons to be adding that on. The admin department relocation is just a dependency so that we could actually move some of the other services and use that for actual clinical work. And then the last one, of course, is the CT renovation, which, more than happy to have that discussion another day. So these are your OR volumes, and I just want you to take a look at this. So when you see it going along, and then all of a sudden you see the jump, that is when we started to do the additional numbers of surgeries. And I'll just see if I've got my numbers here, because I think I did. One here. I think we went from 84 ORs per period, which is usually about a 26 to 28 day session, to the average number is 161 now. So there was a small little drop there in what we call period 1, when that was because we had soft closures. When we do spring break area and Christmas spring break, we usually do some soft closures. Amazingly, people don't want to have as many surgeries during that period. So this has been a significant improvement for sea to sky corridor access as well as others in terms of improving surgery. And I'm almost there. I think I might be. I am. Yep, I'm done. Awesome, good. Thank you. So I don't know if I missed any of the high points of things that would be of interest to you, but
We'll find out.
yeah.
Okay, I have Susan and Peter.
Thank you. Thanks for the presentation. I think that addressed a lot of the points, and I appreciate the between the unions, the authorities, and the agencies, that it's a really difficult process. Healthcare is still a really difficult process to negotiate with budgets and all of those authorities. I wonder about if Vancouver Coastal Health has thought about virtual services and data as well, data services, like actually what technology, as you do your expansions, bringing in the appropriate amount of technology and fiber that will make technology in the future easier to run. And I also, you already addressed the CT scanner issue. I'm glad that
You're not getting one this year. There you
Yeah,
go. It's
I
out
know.
there now. Okay.
Exactly. Yeah, with the number of orthopedic injuries in our community. I'm interested in that as well, as we statistically, the amount of orthopedic injuries and the burden that places on healthcare with the CT scanner in the rooms and the operating rooms. I think that's incredible. That's an incredible thing. But just as far as future space expansion, have the authorities been thinking about, as our community grows and the expected growth, into expanding the hospital or the location of the hospital as well?
Well, I think this is what these many reports, which I didn't bring in with me, but literally it's a stack of these reports we're looking at, but not in a very comprehensive. It was really more looking at blocks.
Small service
Yeah,
units.
and so we need to go down to more look at the functional programming again to say, what are the services that we're seeing expanding? For all of you, there's 2 things I can tell you right now that I see as an issue, and surgery is not one of them, because we have actually made this virtual OR between Lionsgate and Squamish. It's quite amazing. So the surgeries that are appropriate to do up here, orthopedic or not, are done here, and the ones that need to be done in Lionsgate are being done there. So we're very fortunate that way. Very few are transferred out to a higher level of care because our surgeons are quite skilled. But your bigger issue is actually coming in a different way. The number of babies that you're having, they all have to be immunized. And then they're going to grow into children who need to have public health follow-up. Again, still being immunized, but then they're into teens, and then we have sexual health that we need to be looking at. Not to mention the stresses on parents and the daycare and ability to be able to work, you know, and have that happening. So your biggest issue is maybe more in the community infrastructure, which we're focusing a lot on. It's not just to say that Squamish Hospital isn't important, but to address your second point, the virtual technology.
Yeah, I'm just wondering about data collection between, I know another, I do some cities consultation in the States, and the cities that I've seen there are now connected with their healthcare authorities, are connected with their municipalities, with their schools. So there's comprehensive data collection on healthcare and trends in healthcare, including children and immunization and all of those important data points, where you can see where your community is falling off.
Public health is really big on that, working with you. So Mark Lashishin's not here today, but I'm sure you've met him and had reports from him. He's amazing, and he's gone to every community to sign agreements around working together on those very things.
Yes.
So he has that data and certainly shares it with you. Do we have that connectivity? No. Would he love to do it? You bet. Absolutely. No, that would be something that would be amazing to do. The best we have is, you know, me showing up, or, you know, us bringing information to you. But Mark actually gets right down to the granular level, and he can tell you.
We still don't have preventable disease data, like asthma statistics and diabetes statistics. We have no access to those by postal code area, so it's really interesting.
I'm not sure if we do either, but it's some of it we do,
It's
some of it we
really
don't.
valuable for us to actually drill down, like when the Community Foundation does their health profile thing, we get these stats and we don't know how to react to it because it might be totally skewed by something happening in Sunshine Coast or something happening on our shore. So if we can actually start to collect data relevant to our postal code and to our population here and to the trends that we're seeing,
That
then
would be
we
very
can
helpful.
act in terms of how we were built environment or where we focus land use issues and those types of things. So that's what I think Councilor Philp is trying to do.
And I think we can provide some of that, and I'll take that back to Mark, because we are focusing a lot on chronic disease right now, and mental health as well. So some of the data we have, some of it we don't, but what we do have should be shareable with you by postal code, or at least within your community, so you know where your hot spots are. And that's what Mark, if there's something that excites him, is talking about all of this. He gets quite excited about it and looking at it. Obviously youth, he's focused a lot on youth and public health for young families here, because that's where your growth area. The second thing that is of concern, and is for every community right now, is mental health. And so Shannon McCarthy couldn't come today as the Director of Mental Health, and she's been working to obviously get the intensive case management up, but also looking at, okay, what else do we need to do for mental health? And it is not putting some mental health beds in Squamish. I'm just going to put that out there. You need to make sure that you've got a very robust mental health community response, because that's where you want people to be. And when they're sick, you need to have them in a robust environment with not just the bed, but the whole programming around it. So, and have access, timely access to those beds as well. And that's certainly something Shannon's been working on as well. But you want to keep people at home, especially kids. It's hard when you get them into a mental health environment that starts to stigmatize them. So you want to keep them at home as much as you can, and supported with arms wrapped around them.
Peter, I'm cognizant of time, so we'll try to.
I'll keep it kind of short. Just from what I've seen in your presentation, and not to trivialize it, I think the enhancements of service are great, but I'm sort of coming from a brick and mortar type of stance. And I think the constituents that I've spoken to anyway, are more interested in knowing, where the tax dollars are going. We have a lot of people moving here with expectations of facility, and we have, 20,000 more or less in town here, plus everyone up and down the corridor that is expecting to have a hospital-type service, and yet we only have 21 beds available. And I know the assumption, it would seem, is that we have the highway open and we can just send them to Lionsgate. But that isn't really helpful for people that live here that want to have a service that they don't have to travel to, whether it be from a birth standpoint or a sickness standpoint in the family or whatever that may be. So my question to you basically is, what kind kind of a tipping point do we have where there's additions to the brick and mortar part of the facility?
Right. So I'm going to answer slightly differently. Your biggest issue at the time was your births were being transferred out, and we didn't have what I call a robust OB service. So in the last year, we've invested a lot of money to make sure that you've got enhanced OB coverage, not physicians, but actual nursing staff. So that's operating dollars. Your surgical services, your focus has been on daycare surgeries. So again, you're not needing a large number of beds for surgical or overnight stays perhaps, but not a large number for inpatient surgical beds. Your largest number is in your medical beds and your patients that might require a slightly longer convalescence than what can be provided. They need to come in, so your chronic disease management. The idea is we're not building more beds in hospitals, just so you're very aware. So even the new build at Lionsgate, we're not building new beds. We're building a tower with 108 beds, and we're moving 108 over and closing them, because the community infrastructure piece of it is the most important piece of it. If you had a largely aging population, which you don't in Squamish, you have some that are aging, but you're not a seashell where everybody's a gray hair. You have a growing youth population here. You do have people aging, but you don't have it at the same rate.
Not compared to others.
No. We have to be able to support people at home and be able to support them in the community more. So when we add, it will be to add in new technology. So the diagnostic imaging, we may put in a new diagnostic imaging so that we can treat in the community. If you require a higher level care that requires neurosurgery or complex orthopedic surgery, that won't be happening in a population of this size, that the population that doesn't support it, but they would be transferred down and then repatriated back to recover when appropriate. So it'll be more on the technology that we'll be investing in, some of it virtual so that we can care for people in their homes if they have COPD or congestive heart failure, and we can monitor them more closely so they don't tip and come to emerge. It'll be in the diagnostic imaging component of it, which is a growing industry. It may mean we're building new ORs or renovating the new ORs so that we can continue to provide the laparoscopic surgery and new types of surgery. But at this point, the plan, and I would say in the next 5 years, is not to expand the bricks and mortar side of it to add more beds, because everything we're doing is trying to improve the care at home and the infrastructure of home for people and in the community versus having them come in to the hospital. Our occupancy is not such, or our waits for patients to get in and waits from the emerge are not such that we're under a bed crunch either. So it's not being supported to add more beds in at this point. It certainly is, though, for your births and making sure that we're supporting them from when they go home with their parents all the way through up to age 19 and on.
I know you have to work, Karen.
Yeah, it's okay.
So hypothetically, if
Mhm.
we were building a new rec center, which gives us a bit of a green field, and you need a spot for ambulatory rehab, do you have the
Or
ability
dialysis.
or dialysis or whatever it is,
Yeah.
but do you have the ability to move your budget into a community partnership so that
We
you
can
could
provide
share-
operating dollars, yes. We have the operating dollars. We can
Including rent, leases.
Yes, we do that. We do that at West Van, for example. Brand new, beautiful community center they did a few years ago. We moved on to the wrong floor, but that's a whole other thing for moms and babies to get up. But so we'll plan, we'd love to partner on something like that, absolutely, because that frees up space for us to then look at what else can we do to provide services. Chemotherapy is another one. Unless we find a cure for cancer in the next few years, we're going to be seeing an expanded number of people needing chemotherapy and having it closer to home. So we're working with BC Cancer Agency to understand how many more chairs do we need and how much funding will they give us. Because right now we fund a lot of it versus the cancer agency doing that. So there'll be certain services that we will increase in this community so that people don't have to travel. And there's certain things that neurosurgery doesn't make sense to do here. You need to have a certain number and a level of equipment that's ridiculous. Community dialysis does. People shouldn't have to travel 3 times a week to go out of the community. So
I think that ends on a good note, because that's, I think, really the impetus around making sure we have these regular, and we do meet with variety of other people from coastal and for coastal on a number of different fronts. But really we having Vancouver Coastal understand the dynamic that's happening here in
Yeah.
Squamish. I know when I was involved in the master planning process for the hospital a couple of years ago, one of the things they were saying is the projected growth rate just didn't hit the mark that we all thought it was gonna hit. And that was the case back in 2004 to
Yeah.
2014, really. That's not the case anymore.
Yeah.
And even the school district is going, even from 3 years ago, going,
Oh, I
oh
bet.
yeah, all our projections are way off now.
Yeah.
So that is the type of community we have here. I can't see it slowing down.
No.
Our demographic is slightly different than other communities.
Mhm.
We are fortunate that we have a lot of physicians per capita in our community compared to
Right.
other communities in the north. They have terrible problems just recruiting people. So we understand that our problems and challenges are very different than other places. But we
They are.
want to make sure there's this very constant collaborative conversation going on with
Yeah.
PCH to really understand our dynamic. And when we're doing these, expansions of Brennan Park or Municipal Hall or whatever, and when we're looking at and we're keeping those partnership opportunities open.
That would be great, and I mean, my desire is to have more frequent conversations, clearly. I'm up with meeting with the staff and doing forums a lot of the time, but the opportunity to meet with you maybe isn't as often, but I'd like to have those conversations. The opportunity now to have people come rather than relying on one director, so Sujata would be the perfect person to be coming and meeting with you to talk about what we could do with ambulatory care in the community and working. So we have a team now versus reliance and a small amount of attention being paid to the corridor. We now have, as I said, 5 directors who are looking at the Sea to Sky corridor as it's their portfolio. It doesn't stop at the North Shore boundary, wherever that is. So I think you have a lot more opportunity to be working with us. And I'd love to come back. So, I'll bring a different PowerPoint, come up with something new. And it might say still no CT scan, but hopefully a bit more on the other things.
Okay, well, thank you very much.
Thank you.
Everyone
Thank
for
you.
coming. I look forward to continuing the conversation and very much appreciate your time.
Thank you.
Thank you very much. We'll take a 2-minute break just to reshuffle the room.